Hello, my name's Miriam. I'm from the Department of General Practice, and I have with me today Dr. Ali Lyon, who's our academic registrar. We're going to be talking about managing uncertainty in the general practice setting. So by the end of this session, we'd like you to be able to define a clinical approach to presentations with vague or medically unexplained symptoms, be familiar with Murtaugh's safe diagnostic strategy, and be familiar with strategies such as red flags, time, follow-up, patient communication and partnerships, appropriate referral and informal consultation. So in primary care there are challenges and advantages that are unique to the primary care setting. You'll be seeing illness in the community rather than in a hospital setting. You'll be dealing with complexity. Then patients often have multiple medical problems, and very commonly there are social and emotional issues as well which impact on their well-being and on the way that they are navigating their health. You're dealing with early presentations and undifferentiated problems, and there's a delay before test results are available, often a few days. Many advantages though to the primary care setting. You have long-term care of your patients, so you can often work things out over a number of consultations if you need to. You have hopefully a good doctor-patient relationship, and if the patient trusts you, then it makes an enormous difference to how easy it is to sort through and work out their health problems. You have evidence-based medicine at your fingertips, thanks to the internet and online databases, and the help of supportive colleagues. I've only ever worked in general practice settings that had really supportive colleagues, and I've worked in a lot of different settings, and it's very helpful to be able to debrief, run something by somebody, check in for different GPs, have different areas of expertise that you can draw upon, and they'll draw upon yours, and that makes it possible for you to provide really good care for your patients. One example of an uncertain or vague symptom is fatigue, and there's a very wide spectrum of possibilities. For example, this patient could be simply overwhelmed by the rigours of everyday life, such as a single parent who's in need of more support. Or it could be the first subtle manifestation of serious underlying disease. So Murtaugh, who's a professor of general practice from Victoria, has come up with a safe diagnostic strategy that is a very helpful tool. And it centres around asking these questions: what is the most likely or most probable diagnosis? What serious disorders must not be missed? What conditions are often missed? He refers to those as pitfalls. And could this patient have a masquerading illness? And the masquerading illnesses that Murtaugh refers to are, could it be depression, diabetes, drugs, anemia, thyroid disorder, or spinal dysfunction? Is the patient trying to tell me something? Are they experiencing domestic violence? Are they overwhelmed? Are they in bereavement? Are there workplace difficulties? Are they experiencing post-traumatic stress disorder? So Murtaugh recommends that we ask the question, what do you think is wrong, and what did you hope to do today in this consultation? And the patient may say to you, well, actually, I thought my child was okay, but I just wanted you to check. They just want some reassurance. They just want to know that that a doctor also thinks that their child is not seriously ill. So a mnemonic to help you remember those questions is the PROMPT mnemonic. So P stands for probability diagnosis, R stands for red flags, O for often missed, M for masquerades, and PT is patient wants to tell me something. One way of remembering, a mnemonic for remembering the masquerades when you're running through in your mind during consultation, is there anything that I've missed here? What else could this be? Is the mnemonic things are not always cut and dried. So C stands for connective tissue disorder. U stands for urinary tract infection. In elderly people, very young children and diabetics, that can present with vague symptoms such as confusion or high fever or generally unwell, rather than with the dysuria and frequency and the classic urinary tract symptoms. T stands for thyroid disorders. A for anemia. D, depression. R is to remind you to rule out serious and rare causes. I, iatrogenic causes, so check their medication list. Is this a medication side effect? Are they on a beta blocker and that's making them tired? Or are they on a tricyclic antidepressant and that's making them tired? E, is it emotional difficulties? Many people's lives are very rigorous and challenging, and that can often play a role in creating physical symptoms. And D, diabetes. Could it be diabetes? So is she fatigued because she's actually on the way to ketosis and she's dehydrated and hypoglycemic? So we're going to use a couple of patient examples to demonstrate this prompt tool, how you can use this prompt tool in the general practice setting, and I'm going to spontaneously throw some questions at Ali. So Ali, you've got Rami has come in to see you, and he's an 11-year-old boy who woke up this morning with abdominal pain. He's come in with his dad. What would you like to know?
So I guess you want to ask a set of questions in your history, and a good idea is to sort of tailor your questions towards the prompt model. So as you go through, you can sort of build up a picture and build up your differential diagnosis within the prompt model.
Great.
So yeah.
Let's apply the safe diagnostic strategy to Rami. So what is the most likely diagnosis of an 11-year-old boy presenting with abdominal pain? Constipation is the most likely diagnosis. But what serious disorders can we not miss? Acute abdomen. So does he actually have appendicitis or some other cause of acute abdomen? We need to check that through the way that we, as Ali said, the way that we take the history and the way that we do the examination. We'll be tailoring it to, in our minds, excluding an acute abdomen. What conditions are often missed in this kind of child? Early acute abdomen. So perhaps he hasn't got the localised signs yet of, for example, appendicitis, but he's got the general centralised abdominal pain, nausea and vomiting, etc. Could this patient have a masquerading illness? So thinking about, in Rami's context, which of the masquerading illnesses could create abdominal pain? So could it be emotional disturbance? Yes, it could. It could be beginning of diabetes. It could be medications, could be urinary tract, probably not anemia, probably not thyroid. It could be spinal dysfunction, I guess, but it's less likely. And is Rami trying to tell us or tell his parents something? Is he actually experiencing a lot of stress either at school or at home? And it's manifesting as abdominal pain. Children are more likely to get abdominal pain, whereas the older we get, we're more likely to get headaches from stress. So let's use another example. So this is Kelly. She's a 21-year-old and she's presenting with dizzy spells. So I'm going to just throw this over to Ali again without having given her much chance to prepare. Ali, what would you like to know about Kelly?
So I guess if she's a young female presenting with dizzy spells, you'd want to explore that history. How long has it been going on for? Does she have any associated concerning symptoms or red flags, such as a headache or visual disturbance? Things like, is she a vegetarian? Could she be anemic? Linking into the sort of masquerades that Marta discusses. Is she on any medications? Could it be a medication side effect? That kind of thing.
Great. And also, we often at that sort of early stage with the dizzy spells, we'd be trying to elucidate what kind of dizziness. Is it lightheaded, faint feeling, or is there any vertigo? So if it's a lightheaded, faint feeling, it's more likely to be sort of cardiovascular or cerebrovascular. But if if there's vertigo, then it's more likely to be vestibular or could be brain related. So that helps you to work through your different. So the most likely diagnosis for Kelly, what's the highest probability? It could be anxiety. She could be having physiological symptoms of anxiety. It could be vasovagal syncope or pre-syncope, very common in young women. It could be postural hypotension. Maybe she runs at a low blood pressure. Maybe she doesn't drink a lot of water and maybe it's been hot. Or is it a vestibular migraine? Serious disorders not to be missed. Dizziness can cover a lot of different symptoms, and it's an important topic to feel confident in. There is a really good chapter in Murtagh Textbook of General Practice in assessing dizziness. But the serious disorders not to be missed, is it actually an arrhythmia? And so you'd be asking her, does she have any palpitations? In your examination, you'd be checking her heart rate, and you might consider a 24-hour Holter monitor, or if the symptoms keep occurring and you haven't teased through it, you might even talk to a cardiologist about a 7-day event monitor to see if you're missing an arrhythmia. Could it be aortic stenosis? Is it a cerebrovascular event? Is it actually a space-occupying lesion in this young woman? You'd be asking about headaches and neurological symptoms to work that out. Is it a severe infection? When you examine her, you need to know if she has a fever, if she's tachycardic. Is it infective endocarditis? Does she have a history of intravenous drug use? Do you see any of the stigmata of endocarditis? Does she have a murmur? Is she quite unwell? Is she hypoglycemic? Pitfalls or conditions that are often missed with dizziness. It could be an atypical migraine. We talked about arrhythmias. It could be a form of epilepsy. Is it a substance-related issue? Does she have an electrolyte disturbance? A sleep disorder? Or a rare condition such as an atrial myxoma or transient global amnesia? So we would think about the 7 masquerades for Kelly. Could it be depression, anxiety? Could it be diabetes? Yes. Could it be drugs? Yes. They could be prescribed drugs, or they could be recreational drugs. Could it be anemia? Yes. Could it be thyroid? Yes. Could it be cervical spondylosis causing dizziness and urinary tract infection? And is the patient trying to tell me something? I'll just throw that one back to Ali. You know, young women presenting with or young people with a vague, undefined symptom such as dizziness. Have you had any patients where it's later turned out to be a psychosocial issue that they were needing help with?
Yeah, I guess I've had young adolescent patients come in with symptoms which seem quite vague, which turn out to be things related to their family situation at home, whether it's parents going through a difficult separation, or whether they're in a destructive relationship, whether there's domestic violence occurring. So I think, often there is a hidden agenda that the patient has. It's really important to give the patient space and time to sort of explore that.
Great, thanks, Sally. And I guess something that just popped into my mind then too is just quickly checking her beta-HCG to make sure that she's not dizzy due to being pregnant. So you could do a urine, look for her sugar, look for her beta-HCG, check if it's a UTI. Urinalysis is a really helpful general practice desktop tool. So Lawrence has already talked about the some of the approaches that you can use to getting a better understanding of your patient's situation, the ideas, concerns and expectations approach to a patient-centred consultation. Another way of doing that is to explore what is it, is there anything in particular that you're worried about, fears? What ideas do you have about what might be going on? How are you feeling about what is going on? And do you have any particular expectations, or what were you hoping that we could help you with today? Another aspect of communicating with patients is combining both honesty and confidence. So letting them know that whilst we haven't narrowed down to a specific diagnosis, we have gone through a thorough process of ruling out serious diseases, And part of my role in looking after you is to make sure that we rule out serious diseases, but also don't put you through the patient through too many unnecessary investigations. So you've been monitoring the situation, deciding whether an investigation is appropriate or not, and sharing your thinking process with the patient about that, and asking them certainly to come back and see you if any symptoms change or deteriorate or don't go away, and giving them a suggested time frame, such as if you're not starting to feel better in the next 48 hours, then I'd like to see you again then. If you're actually getting worse, I'd like you to go to hospital. So you tailor it to the symptom that you're managing. And most of all, be supportive. Just because there isn't a diagnosis that we can label for their symptom, it doesn't mean that they're not suffering. And patients often just want to be heard that what they're experiencing is difficult. Sometimes as a doctor you feel this pressure to make a diagnosis, and doctors can feel tempted to be dismissive of patients when there isn't a diagnosis because they're actually feeling uncomfortable themselves that they haven't been able to make a diagnosis. So remember that, to be supportive of the patient and what they're going through. Safety netting red flags. So for example, if a child with respiratory symptoms, you'll teach the parent how to identify respiratory distress. If your child starts to teach them how to identify tracheal tug, subcostal recession, intercostal recession, show them what it looks like, or demonstrate to them on their child. If you see that tonight when you go home, I want you to go to hospital. If your child's still coughing or has a fever tomorrow, I want you to bring them back to the general practice, that kind of thing. With the boy with abdominal pain, if he develops a fever or he can't sleep with the pain, then we need to see him again tomorrow. That sort of safety netting, so tailoring it to your symptoms, but making sure that you've covered those serious disorders that must not be missed, and given the patient information about when to represent. In summary, using a patient-centred approach, work with the patient, use those GP questions, will really help you to get to the bottom of the patient's conditions or symptoms, or at least to manage them in a safe way. Use the safe diagnostic strategy, use the prompt tool, and use time if you need it. So you can get that patient back in a few days, you can get them back next week, you can call them later on. Sometimes if I've seen a child, I'll often call the parent towards the end of the day and just say, how's your child going now? And check, because often they've improved, and if they haven't, the parent will really appreciate you calling, and you can sort of troubleshoot, do they actually need to go to hospital or do they need to see you the next day? And the way their symptoms develop will really help you in your diagnosis as well, so seeing how symptoms change over time. There's some references for you that we've drawn upon in giving this lecture today, and thank you to Ali for her contribution. We'll see you at conference week.